would be smoother, because I think within the innovation that's allowed, I know it refers specifically to Medicaid. So Medicaid is paid half and, well, traditionally half and half, but under healthcare reform, actually the federal government pays more of Medicaid. So based on what they know about the demographics of our state, we would ask the federal government to give that subsidy to the cooperative. And so everybody would be part of the same system, so we wouldn't have people you wanted to avoid because they were Medicaid or Medicare. We would all be the same. Medicare, there would be two options. One is, right now, the federal government will allow insurers to offer a Medicare HMO plan where they get a per member per month rate. So, so if you're Medicare, and let's say you chose to become part of Kaiser, you could choose to become part of the cooperative with your Medicare and have all the health care that's available to people in the cooperative. Or if you're Medicare and you're thinking, this sounds too funky, I don't trust it, you could stay Medicare, and then the cooperative would be like your secondary insurance and pay whatever Medicare doesn't pay for you, up to the limits of the cooperative.
How could the doctors somehow be insulated from knowing who's paying more and who's paying less?
Oh, it'll be a conscious decision on the part of the doctor to charge more or less. So otherwise they get, my vision would be actually that most physicians would be salaried. And you know, people always say, oh, the specialists will never go for that. Well, specialists are being forced to go for that in the way that healthcare is evolving now. Actually in big old downtown Denver, a number of cardiologists are now on staff at hospitals because they're not able to maintain a private practice because of what Medicare has done with funding to cardiologists. And most of the time people who need heart procedures are older, and so Medicare funding really impacts that. What Medicare found out was that as soon as they were paying so much for cardiac procedures, a bunch of cardiologists were opening up these fancy freestanding clinics and billing them for money, so they cut the rate 75%. And those clinics are closing, and cardiologists are having trouble recovering their costs and are now becoming part of the staff of hospitals. So, so I think the model of physicians being salaried is not as outrageous as it was 20 years ago. We're moving that way. I have a friend who has been in Best Doctors in Denver a number of years. It's this beautiful office at Swedish Hospital with, you know, wall-to-wall windows looking at the Rocky Mountains, primary care, internal medicine. And this year, their income was less than a Kaiser physician was making, and they're selling their practice to Swedish Hospital as of April 1st because they can't let go of it alone. So it's already happening. So most of the time, so a patient is a patient is a patient, unless you're one of those providers who says, you know, I'm special and I only want to treat really special people, and then they come to you knowing that the system pays X and they pay the difference out of pocket.
Yeah, I just wanted to announce I was reading my email this morning, and Congressman Dennis Kucinich of Ohio will be reintroducing H.R. 676, Medicare for All, this year.
So let's talk a little bit about actually where single payer is at. As you know, it was kept from being discussed as part of national health care reform. There are a lot of theories out there on the internet, and I was not in Washington, D.C., so I can't tell you what really happened. Some of the theory was that when Hillary Clinton tried health care reform, the large insurers and pharmaceutical companies were able to sink it because they didn't buy in and they really subterfuged it with the media. And so the president pulled in the pharmaceuticals and insurers early on to try and get the cooperation for moving forward with health care reform. And basically, the theory is that compromise and single payer was taken off the table. And so I think that a lot of people now, because of that, because Obama used to profess that he believed in single payer health care, because that happened, a lot of people really thought single payer would never just happen at a national level, but that, like Canada, if it were to happen in one state, the opportunity for others to learn from it and to propagate that idea would be there. And so in Vermont, their governor's race, they were, one of the candidates who won was a strong supporter of single payer, and their legislator is a supporter of single payer, and they've had a study that just came out January 19th by Walter SAIO, and he's the guy who designed the healthcare system in Taiwan. As you know, Taiwan went to a single-payer system in about 1998 or 4, somewhere along there. Anyway, he came out with a report for Vermont and how they could fund and finance and do a single-payer healthcare system. And Vermont is will be applying to Congress for the waivers to implement single-payer healthcare in the state of Vermont. Now, Vermont has about 600,000 people, so it's a pretty small state. We're at about 5.5, 6 million. Raleigh probably knows the exact number because he's doing redistricting. What's our number, Raleigh?
5.1.
5.1? Oh, I thought we were bigger than that. So, a little bit harder there, but literally in Vermont, their grassroots activists estimate that they actually talk to every single person in the state about this, and a few cows, I think. and so with some luck, in a year or two, the state of Vermont will be on a single-payer healthcare system, and we could see what happens with it.
Do they have a different sort of campaign financing than we do here?
I remember they have Bernie Sanders,
They do have.
and he's a socialist, isn't he?
Very different system.
Do they?
There's no, it's all public financing of doing that.
Well, see, that could make all the difference. That's what
Yeah.
concerns me.
Yeah. Yes, ma'am.
When we're talking about the card system, how does that work if you're not in the state? So,
Yeah,
is that
probably.
information?
Yeah, sort of like right now. So right now, if something happens, you're out of state, the hospital faxes a release to the
Okay.
system, and they get,
So
your
it
records.
would be sort of from that central backup system?
Yeah,
that it would
exactly.
come? Okay.
So 2 questions. One is a timeline, like when you envision this, what the timeline is for it. And the other thing is just that it's so interesting when you said the 5% thing, because I think that's a brilliant idea, because for us, 5%, we pay way over 5% already, and we have what they call catastrophic. So we get
Right.
pretty much nothing for way, and we're self-employed for way more than 5%, and we just pay in, and we never get anything. So I think it would be great to have 5%. Sounded great.
Yeah. In addition to that, you're afraid to use it because you're afraid that that data is captured in your label, and then your rate is going to go up. And so it really disincentivizes taking care of your health care. And there was an interesting study, again, done out at, I think it's in California, and I don't know if it was Kaiser or another system, but they were concerned about how many of their seniors were coming in and seeing doctors and doing doctor visits all the time because they had really low co-payments. So they significantly increased co-payment charges. And as you would expect, far fewer people came in. But the overall system costs increased because people weren't taking care of their health, and these were seniors. I mean, you were so shooting yourself in the foot, making it hard for them to take care of themselves. And so, so they dropped the program after 1 year and went back to the low co-payments because it was costing them more. So, but in our current market, because you switch and switch and switch between insurers, they're willing to take that gamble. It's not going to cost them so much to inconvenience you, and the odds are in their favor. Now, for you, this is the one life that you have. You really don't want to gamble with it. But the reality is when you don't have much money and you're choosing whether to really go see somebody about that nagging cough or, be sure you're on time for your rent, or that you don't have to turn your heat down 5 more degrees when it's snowing. I mean, people make those kinds of decisions every day. And we want to change that. We want people to be incentivized to get health care. Now, that doesn't mean I want everyone going to the doctor. I want them to have a phone they can call and say, this is how I'm feeling, what should I do? And the people on the other line want to help you because they don't want you to come in and see them because it costs them more money if you come in to see them. But at the same time, they don't want you to get sick because, if you die, they don't get their premium anymore.
Whereas now, if you die, that's a cost savings.
It is. Well, or if you don't get sick until you're over 65,
Yeah.
then it's Medicare.
This is a little bit off subject, but I was just wondering what you felt about when, in 2014, if this thing continues as it is, and I guess we're hoping it